Welcome to the deep dive. Our mission here is pretty straightforward. We take complex information like the source material you've got there, and we try to unpack it together. Find those essential insights, maybe some surprising facts, to help you really get informed. Today we're diving into a truly critical topic, lung cancer. We've got chapter 78 on neoplasms of the lung from a key medical text as our source. Lung cancer is still a huge health challenge, right? But as the chapter highlights, it's also a field seeing some significant changes and improvements. Our goal for this deep dive is to really go through this chapter, understand the key concepts, and we'll get a solid grasp on this complex disease and how it's managed today. We want to master this info just like the experts.
That's exactly right. This chapter gives a really comprehensive view. It takes us all the way from the history and the epidemiology right through to the latest understanding of its molecular basis, how it's diagnosed, staged, and the evolving treatment approaches. That's for both small cell and non-small cell lung cancer. It even touches on some related rare tumors and the very recent impact of the COVID-19 pandemic.
Okay, so let's unpack the source. Let's explore the nuances of lung neoplasms together. Our source kicks things off by framing lung cancer's history and its current impact. It really sets the stage for just how significant this disease is now, especially when you think about how recently it became so prominent.
Yeah, that's one of the most fascinating things here, how recent its prominence really is. The chapter describes it as essentially a disease of modern man. It was incredibly rare before 1900. I mean, think about it. Fewer than 400 cases documented in the entire world's medical literature before the 20th century.
Wow. That's almost unbelievable. To go from being that rare, practically unheard of, to, the source says it is now.
Exactly. And despite that historical rarity, it was largely fueled by the rise of mass-produced cigarettes in the 20th century. Its incidence just exploded, and it rapidly became, and sadly remains, the number one cause of cancer-related mortality worldwide. The chapter points out it kills far more men than prostate cancer and, tragically, nearly double the number of women than breast cancer in the U.S. That stark contrast, between its history and its modern impact.
Yeah.
It's really profound.
That is a striking contrast, a really stark picture. But the source also mentions a decline in deaths from this number one killer. So how can it be the leading cause of death but also be declining? What does that mean?
Well, the decline is attributed to some crucial improvements across several fronts, as the chapter details. It points to better testing strategies, enhanced therapeutic approaches that are genuinely getting more effective, and importantly, a significant and sustained decline in tobacco usage, especially cigarette smoking, which is, the primary driver. This decline in smoking, it links directly back to major public health efforts. The source specifically mentions the impact of the U.S. Surgeon General's landmark 1964 report.
Right, the big report on smoking and health.
Exactly. After that report, cigarette use began a slow but steady decline, particularly in North America and parts of Europe. And as you'd expect, years later, following that drop in exposure, there was a subsequent drop in lung cancer incidence rates and consequently mortality rates.
That makes sense. You tackle the main cause, eventually the numbers should change. Okay, let's dive deeper into those numbers then, and the why behind lung cancer development. Let's look at the epidemiology and the specific risk factors the source details.
Yeah, the epidemiology really confirms its huge impact in the U.S. In a recent year cited in the chapter, around 228,000 people were diagnosed and over 135,000 died. It is, like we said, the most common cause of cancer death for both American men and women. The chapter notes it's pretty uncommon under the age of 40. The rates increase, and they peak around age 80 before tapering off just a bit.
So mostly a disease of older age then?
Largely, yes. But the chapter gives the lifetime probability, estimated around 8% for males and about 6% for females in the U.S. The source also points out these interesting variations by race and ethnicity. Rates are highest among African Americans, particularly men, and notably for women under 50, mortality is over 25% higher among African American women compared to Caucasian women. Rates are generally lower among Hispanic, Native, and Asian Americans compared to whites.
So while smoking is clearly the main thing, the picture of who gets it and who dies from it has these other sort of complex dimensions. What are the specific risk factors the source really digs into beyond just smoking status?
Well, cigarette smoking is absolutely paramount. It increases risk tenfold, maybe even more, compared to never smokers. And the source gives this fascinating and very sobering detail from a large genomic study. On average, one genetic mutation is induced for every 15 cigarettes smoked.
15? Wow. That really quantifies the biological hit in a very concrete way.
It really does. Just think about that cumulative DNA damage over years and years of smoking. And the good news, highlighted again in the chapter, is that quitting smoking dramatically reduces this risk compared to continuing. The chapter emphasizes that the risk reduction gets significantly better the longer a person has been quit. But, and this is really important, even long-term former smokers still have higher risk compared to people who have never smoked at all.
So the damage doesn't completely disappear?
Not completely, no.
Okay.
The risk goes down a lot, but it doesn't reach zero. And the chapter also makes it clear. Cigarette smoking increases the risk of all major types of lung cancer, not just one specific subtype.
Okay. What about non-smokers? Secondhand smoke?
Right. Beyond actively smoking, environmental tobacco smoke, ETS, what we usually call secondhand smoke, is also an established cause. The source notes the risk from EPS is real. It increases lung cancer risk by about 20-30% among never smokers who are married to smokers for many years. But, it's crucial to put that in perspective. That risk is orders of magnitude lower than from active smoking, which is closer to a 2,000% increase. So it's a risk, but much smaller than smoking yourself.
Okay. And what about vaping e-cigarettes? That's a big topic now.
Yeah, and here's where it gets particularly interesting and represents a newer challenge. The impact of these alternate nicotine delivery devices, like e-cigarettes or vaping. It's currently undefined in terms of long-term lung cancer risk. We just don't have the decades of data we have for traditional cigarettes.
Yep, too new.
Exactly. The source does mention one large trial found e-cigarettes were superior to traditional nicotine replacement therapy for helping people quit smoking. So there's a potential indirect benefit if they help people get off traditional cigarettes. However, the emergence of e-vali, that's e-cigarette or vaping-associated lung injury, presents these acute, sometimes serious risks. And those risks could potentially counterbalance any potential long-term benefit if these devices aren't used strictly for quitting cigarettes. It's a really rapidly evolving area.
Lots of unknowns there. What about risks beyond tobacco? Occupational hazards?
Definitely. Moving beyond tobacco, occupational exposures are identified as key risk factors.
Yeah.
The source lists several established causes, things like asbestos, arsenic, hexavalent chromium, mustard gas, and certain processes in nickel refining, among others.
And radiation.
Ionizing radiation is also a confirmed carcinogen. This is known notably from studies of atomic bomb survivors and also underground uranium miners exposed to radon gas. And the chapter highlights a point that's relevant to a lot of people, not just miners. Prolonged exposure to low-level radon in homes in residential settings might carry a risk of lung cancer comparable to or maybe even greater than that from secondhand smoke.
Wow. So check your basement for radon.
It emphasizes it's not just an occupational issue. It can be a home environment concern for some. The source also links prior lung diseases to increased risk, specifically chronic bronchitis, emphysema, and tuberculosis. And interestingly, it notes a higher risk associated with low fruit and vegetable intake.
Oh, so diet plays a role.
Well, that association led to hypotheses about using retinoids or carotenoids, vitamin A-related compounds, for prevention. But the chapter states pretty clearly, large randomized trials failed to actually validate this dietary supplement approach for prevention.
Okay, so diet link is maybe correlational, not causal for prevention. What about genetics? The source discusses inherited predisposition. How much does that play a role compared to smoking and radon and asbestos?
It's complex. It's really an interplay. Environmental carcinogens are the primary drivers. They cause the mutations. But our individual susceptibility to those effects seems to be modulated by subtle genetic differences, these polymorphisms, in genes that handle things like breaking down carcinogens. Now, the contribution of any one specific genetic variant might be small for an individual, but because they're common in the population, their overall impact on population risk could be pretty significant.
So some people might be genetically more vulnerable to smoke damage than others?
That's the idea. And the strongest evidence for this genetic component comes from family studies. The source cites some striking data. First-degree relatives of lung cancer patients have a 2 to 3-fold excess risk of lung cancer themselves. And interestingly, they also have a higher risk of other cancers that aren't typically smoking-related.
That does suggest something inherited.
It strongly suggests specific genes or variants contributing to susceptibility are being passed down. However, the chapter is clear. Very few specific genes have been identified so far that account for a large portion of this inherited risk. We know individuals with rare inherited mutations in major tumor suppressor genes like RB or P53 can get lung cancer, but that's very rare. More commonly, variants near genes involved in nicotine addiction or telomere maintenance have been linked to risk, especially in smokers. and interestingly, some rare germline mutations, like a specific EGFR mutation called T790M or a specific spot on chromosome 6q. These have been linked to susceptibility specifically in never smokers.
Okay, so some genetic links, but maybe not the whole story for most people.
Right. The takeaway here, as the source really emphasizes, is that despite this progress, a lot more work needs to be done to identify clear heritable risk factors. And currently, we don't have specific molecular criteria that we can use to select individuals for more intense screening or prevention based purely on their genetics. Environmental exposure, especially smoking, remains the absolute dominant factor.
Okay, so environmental factors first, genetics second. Got it. Moving from the why and who to what it actually is at a cellular level. How are lung cancers defined and classified based on our source? This seems absolutely fundamental because it dictates treatment, right?
It is absolutely fundamental. The World Health Organization, the WHO, defines lung cancer by its origin.
Yeah.
The respiratory epithelium, those are the cells lining the bronchioles and the alveoli, the air sacs. And the classification system is crucial because, as the source highlights, the natural history, how the cancer behaves, and the treatment approaches differ significantly based on the type.
So what are the main types?
The WHO divides these epithelial lung cancers into 4 main microscopic types. There's small cell lung cancer, or SCLC, then adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. And those last 3, adenocarcinoma, squamous, and large cell, are often grouped together as non-small cell lung cancer, or NSCLC.
Okay, SCLC and NSCLC, how do they tell them apart?
SCLC has a really distinctive look under the microscope. The cells are small, they don't have much cytoplasm, the chromatin in the nucleus looks fine and granular, and there's a high mitotic count and lots of cells dividing. Immunohistochemistry, using special stains, helps confirm it. They look for neuroendocrine markers like CD56 and chromogranin.
And the NSCLC types.
Adenocarcinomas show signs of forming glands or producing mucin. They can have various patterns like acinar or papillary. Squamous cell carcinomas look more like squamous cancers you might see elsewhere, like the skin. They show keratinization, or these things called intercellular bridges, and they typically arise from the lining of the bronchi. Large cell carcinomas are sort of the leftover category, less common, the ones that don't clearly fit into the other NSCLC types based on their appearance. Together, these 4 types make up about 90% of all epithelial lung cancers.
Did these different types line up with smoking history at all?
Yes, they do, but there are some important trends to note. All types can occur in smokers, absolutely, but squamous and small cell types are the ones most strongly linked to heavy tobacco use. However, and this is a key trend the source points out, as cigarette use has declined, adenocarcinoma has actually become the most frequent type, especially in the U.S. It's also the type that's more common in lifetime. Never smokers, former light smokers, women, and younger adults, say under 60.
Interesting shift. The source really emphasizes the importance of distinguishing SCLC from NSCLC, and then within NSCLC, separating squamous from non-squamous. Why is that distinction so critical for treatment decisions?
It's absolutely vital because SCLC and NSCLC are treated completely differently. SCLC is typically managed with chemotherapy and radiation, very rarely surgery, because it spreads so early and widely. NSCLC treatment, on the other hand, depends heavily on the stage, but often involves surgery, targeted therapies, or immunotherapy, and the specific choice depends heavily on the subtype and the molecular profile.
And within NSCLC, squamous versus non-squamous.
That distinction is critical for optimal therapeutic decision-making. For example, the chapter explains that certain chemotherapies, like pemetrexed, work much better and are actually less toxic in non-squamous types, like adenocarcinoma, compared to squamous types. And that difference seems related to the levels of a specific enzyme, thymidylate synthase, within the cancer cells.
Wow, okay, so the cell type directly impacts chemo choice.
Exactly. Now, a practical challenge is that many advanced cancers are diagnosed from really small biopsies or cytology samples, making that definitive classification tricky sometimes. The source notes that the diagnosis non-small cell carcinoma, not otherwise specified, or NS, well, that's actually no longer considered acceptable by current standards.
Because you need more precision now.
Exactly. It reflects the precision needed today. Often, immunohistochemistry using specific antibody markers is needed to make the distinction when the morphology alone isn't crystal clear. They use markers like TTF1 or napsin-A for adenocarcinoma and P40 or P63 for squamous differentiation. And critically, the source stresses this when getting tissue, you have to make sure enough material is preserved. Not just for the basic pathology diagnosis, but also for the molecular testing and the PD-L1 testing, which are absolutely essential for guiding modern therapy, especially for advanced NSCLC.
Right, gotta save some tissue for those downstream tests. The source also mentions updates to the classification systems, particularly for adenocarcinomas.
Yes, there's an integrated approach now, particularly for adenocarcinomas. For small ones, say 3 centimeters or less, specific growth patterns are now recognized. Patterns like pure lipidic growth, which looks like cells growing along the existing lung structure, or predominantly lipidic with just minimal invasion, like 5 millimeters or less. These are classified separately now.
Why is that important?
Because the key insight here from the source is that these specific patterns, even though they're technically cancer, have a near 100% 5-year disease-free survival rate if they're completely removed surgically.
Basically cured by surgery alone.
Essentially, yes, for these very early specific forms. It helps identify patients who likely don't need more aggressive treatment. Invasive adenocarcinomas are then classified by their predominant pattern, lipidic, acinar, papillary, solid, and these different patterns have different prognosis. Lipidic is favorable, solid is generally poorer.
That level of detail in pathology really impacts how you think about prognosis and treatment, especially for those early lesions. Okay, now the source shifts to the molecular level, how these cancers actually develop. It mentions the concept of hallmark capabilities.
Yeah, this is a really key concept from cancer biology, proposed by Hanahan and Weinberg. It refers to the idea that pretty much all cancer cells, regardless of where they start, acquire a set of core abilities. Things like being self-sufficient in growth signals, evading programmed cell death, apoptosis, having limitless replication potential, stimulating blood vessel growth, angiogenesis, and the ability to invade tissues and metastasize.
So a common set of tricks they all learn.
Kind of, yeah. These capabilities are acquired through the accumulation of genetic mutations over time, both activating genes that promote growth oncogenes and inactivating genes that normally put the brakes on growth tumor suppressor genes.
Okay, and the source then dives into something called driver mutations, which sound particularly important.
They are incredibly important. Driver mutations are specific genetic changes, aberrations, in genes that encode signaling proteins. And these proteins drive the tumor's initiation and continued growth and survival.
So they're like the engine of the cancer.
That's a good way to think of it. And they're crucial because they represent potential Achilles heels for the cancer. If you can develop a drug that specifically targets the protein product of that mutated driver gene, you can potentially shut down a pathway that's absolutely essential for the tumor's existence.
That's the basis of targeted therapy.
Exactly. Many of these driver mutations are found in genes that encode cell surface receptors, often ones with tyrosine kinase, or TK, domains. Normally, these receptors need an external signal, ligand, to bind and activate them. But with a driver mutation, they become constitutively active. They're just stuck in the on position. They're constantly telling the cell to grow, divide, make blood vessels, spread, and resist dying, even without any external signals.
Okay, and the source lists specific genes where this happens?
Yes, especially in lung adenocarcinomas, which are the most extensively studied. Genes like EGFR, ALK, ROS1, BRAVE, MET, KRAS, PK3CA. Tumors that have these specific driver mutations are often highly sensitive to drugs called small molecule tyrosine kinase inhibitors, or TKIs, that target those specific mutated proteins. Other types involve specific chromosomal rearrangements that activate TKs, like an ALK, ROS1, and TRK-R8T.
And these drivers, they usually occur one at a time.
That's a crucial detail the source highlights. Most driver mutations appear to be mutually exclusive, meaning a tumor usually has just one primary driver mutation pushing its growth.
That simplifies testing, maybe?
It helps guide testing, yeah. You look for these specific, generally non-overlapping mutations. And while most of this work has been in adenocarcinomas, the source notes some targets are found in squamous cell lung cancers too, like FGFR1 amplification or mutations in DDR2 or PIK3CA. The source includes a table, Table 781, which clearly illustrates these different driver mutations, how common they are, and which lung cancer subtypes they're typically found in. It's a great summary.
So activating oncogenes is one part. What about the brakes, the tumor suppressor genes?
Right, they're equally critical. The chapter emphasizes that many tumor suppressor genes are inactivated during lung cancer development. This includes major ones like TP53 and RB1. The source notes nearly 90% of SCLCs have mutations in both of these. Also genes like RS, S1A, CDKN2AB, LKB1, and FHIT. And crucially, the chapter points out that several tumor suppressor genes located on chromosome 3P seem to be involved in nearly all types of lung cancer. Loss of genetic material in this region is thought to be a very, very early event in the path towards cancer, sometimes even seen in tissue that looks normal but has been damaged by smoking.
So it's a combination of pushing the gas pedal with oncogenes and cutting the brakes with tumor suppressors.
Exactly. That molecular understanding is what really underpins the targeted therapies we hear so much about now.
Okay, that makes sense. Now let's shift gears to early detection. We know outcome is related to stage at diagnosis. So does detecting lung cancer earlier actually improve survival? The source tackles this critical question with screening data.
Yeah, that's the million-dollar question, isn't it? The logical assumption is yes. Find it small, cut it out, cure it. But historically, as the chapter notes, most patients presented with advanced, incurable disease. And those early randomized trials back in the 60s, 70s, 80s, the ones using screening chest x-rays, sometimes with sputum cytology, they actually failed to show a reduction in lung cancer deaths in high-risk groups.
That's surprising. Why didn't x-rays work for screening?
Well, the trials faced criticism for their design. But fundamentally, chest x-rays just aren't sensitive enough to pick up cancers when they're really small and most curable. They often miss them until they're larger.
So standard chest x-ray wasn't the answer, but the source introduces a new tool that really changed the game. Low-dose computed tomography, or LDCT.
Exactly. LDCT scans use lower radiation than a standard CT, but are far, far more sensitive at picking up small nodules in the lungs compared to a plain chest x-ray. Non-randomized studies in the 90s started suggesting LDCT could find more nodules and, crucially, more early-stage cancers. This preliminary evidence led to the landmark National Lung Screening Trial, the NLST.
The big one. Tell us about that.
Yeah, the NLST was a huge, well-designed randomized study. It compared annual screening with LDCT versus annual screening with standard chest x-ray. It enrolled over 53,000 high-risk individuals in the U.S. defined by specific age criteria, 55-74, and a heavy smoking history, at least 30 pack years, current smoker, or quit within 15 years. That definition of high risk was key.
And what did they find?
The results were genuinely practice-changing. LDCT found significantly more cancers overall compared to chest x-ray. And critically, nearly double the number of cancers found with LDCT were stage IA, the earliest, most potentially curable stage. About 40% is 21%.
So it found more cancers and found them earlier. Did it save lives?
Yes, that was the major finding. A significant 20% reduction in mortality from lung cancer in the group screened with LDCT compared to the chest x-ray group. There was even a smaller, but still significant 6.7% reduction in death from any cause in the LDC2 group.
Wow, a 20% reduction in deaths from the number one cancer killer.
Yeah.
That's powerful. What does the number needed to screen mean here? The source mentions it.
Yeah, that's an important metric for evaluating screening programs. The number needed to screen, or NNTS, was calculated from NLST data as 320. That means for every 320 high-risk individuals screened with LDCT instead of chest x-ray over the trial period, one lung cancer death was prevented. It gives you a sense of the scale of the intervention needed to achieve that benefit. You need to screen quite a few people to prevent one death.
Okay. And the source also mentions the Nelson study, another big trial.
Right. The Nelson study was another major randomized trial conducted in the Netherlands and Belgium. It compared CT screening at specific intervals to no screening at all in smokers. And Nelson also found a significant reduction in lung cancer mortality, about a 26% reduction at 10 years for men, with a strong trend towards benefit in women too.
So these two huge trials, NLST and Nelson, basically validated LDCT screening for high-risk people.
They did. They provided the high-level evidence showing that annual CT scans can lead to earlier detection and reduced mortality from lung cancer in carefully selected high-risk populations.
But screening isn't perfect. It isn't without risks. What does the source highlight as the downsides or challenges?
Yeah, the chapter is very balanced on this point. Screening definitely comes with risks and potential harms. The most significant one, highlighted repeatedly, is the incredibly high false positive rate.
False positives, meaning the scan looks suspicious, but it's not cancer.
Exactly. In the NLST, over 96% of the positive screening results, the suspicious findings on the scans, turned out not to be cancer after further workup. The rate was similarly high with chest x-ray too, by the way.
Over 96%? That's staggering. What are the consequences of that?
Well, these false positives aren't trivial. First, there's the anxiety and stress for the patient who's told they might have cancer. And second, they lead to more tests and procedures, follow-up CT scans, sometimes invasive biopsies like fine needle aspiration or even bronchoscopy, occasionally even surgery, all to rule out cancer that isn't actually there. These follow-up procedures carry their own risks, discomfort, and of course significant costs.
So the downstream impact of false alarms is huge.
It's the biggest challenge, yeah. The source also mentions other potential harms. False negatives, missing a cancer that's there, the potential for overdiagnosis.
Overdiagnosis, what's that?
That's finding very slow-growing, indolent cancers that might never have actually caused the person any harm or symptoms if they hadn't been found by screening. Detecting and treating these might not actually benefit the patient. Other risks include cumulative radiation exposure from repeated scans, although it's low dose, and the substantial financial cost of implementing a widespread screening program, both for the initial scans and all the follow-up.
It sounds like a complex balance of benefits and harms. How should doctors and patients navigate this?
The source emphasizes the need for shared decision-making. It suggests using absolute risks rather than just relative risks, like the 20% reduction, when discussing screening with patients, because studies show people understand absolute numbers better. It even includes an example table, adapted from another study, showing the NLST results in absolute numbers per 1,000 people screened. For example, 4 fewer people died from lung cancer with LDCT versus CXR screening, but 223 more people had a false alarm requiring follow-up. Seeing both sides like that helps patients weigh the pros and cons for themselves.
That transparency seems crucial. Okay, let's move on to how lung cancer typically shows up clinically. Our source details a really wide range of signs and symptoms.
Unfortunately, yeah. The chapter notes that over half of patients, maybe 50-60%, present with locally advanced or metastatic disease already. So symptoms are common at diagnosis. And these symptoms can arise from the primary tumor itself in the lung, from its spread to nearby structures or lymph nodes, regional spread, from spread to distant parts of the body, distant metastases, or interestingly, from these things called paraneoplastic syndromes.
Who typically gets these symptoms?
Well, the prototypical patient described is a current or former smoker, typically around age 70. A key clinical pearl mentioned is that a chronic cough, maybe with some blood, hemoptysis, especially in a smoker over 40 who also has COPD, that should trigger investigation, even if their chest x-ray looks normal initially. Also, a persistent pneumonia that just doesn't clear up with antibiotics warrants evaluation for an underlying blockage.
What about non-smokers?
For never smokers, the source notes lung cancer is statistically more common in women and people of East Asian descent, and often diagnosed at a younger age than in smokers. But the way it presents, the symptoms, are generally similar.
Okay, let's break down the symptoms based on where the cancer is growing, like the source does. Central versus peripheral.
Right. Central tumors growing in the main airways, bronchi, can cause cough, hemoptysis, coughing up blood, wheezing or stridor, noisy breathing, shortness of breath, dyspnea, or recurrent pneumonia behind the blockage, post-obstructive pneumonia. Peripheral tumors growing out near the edges of the lung are more likely to invade the pleura lining of the lung or the chest wall, causing pain. They could also cause restrictive shortness of breath, or if they cavitate, form a hole, symptoms like a lung abscess.
And if it spreads nearby, regionally.
Regional spread, either by direct growth or through lymph node metastasis, can cause significant problems. Things like tracheal obstruction, difficulty swallowing, dysphagia if it presses on the esophagus, hoarseness if it affects the recurrent laryngeal nerve, controlling the voice box, an elevated hemidiaphragm, and shortness of breath if it paralyzes the phrenic nerve controlling diaphragm movement, or Horner's syndrome if it hits the sympathetic nerves. That's the classic triad of a droopy eyelid, apoptosis, small pupil meiosis, and decreased sweating anhidrosis on one side of the face.
Wow, nerve involvement causes a lot of distinct signs.
It does. Also, malignant pleural effusions, cancer cells causing fluid buildup around the lung, cause pain, shortness of breath, and cough. And Pancoast tumors, those specific ones growing right at the apex, the very top of the lung. They often invade the brachial plexus nerves, C8, T1, T2, causing severe shoulder pain that radiates down the arm in an ulnar pattern, often with bone destruction of the ribs. Pancoast syndrome and Horner's syndrome can definitely occur together.
Any other regional issues?
Yes, superior vena cava, SVC syndrome, for obstruction of the large vein draining the upper body, causing facial swelling, arm swelling, prominent veins. Pericardial involvement can lead to fluid around the heart, tamponade, arrhythmias, or heart failure. Lymphatic obstruction can cause pleural effusions. And lymphangitic spread, where tumor grows along the lymph channels within the lung tissue itself, can severely impair gas exchange, causing profound shortness of breath and low oxygen levels.
And just general symptoms, feeling unwell.
Right. Constitutional symptoms are common too. Anorexia, loss of appetite, significant weight loss, weakness, sometimes fever or night sweats. The source notes these often don't really help distinguish between SCLC and NSCLC, or even from metastatic cancer from somewhere else, except maybe the duration of symptoms might differ sometimes.
Okay, and what about distant metastases? The source says they're very common, especially found at autopsy.
Extremely common, yes. Found in over 50% of squamous cell cancers, 80% of adenocarcinomas and large cell, and over 95% of SCLC cases at autopsy. And about a third of patients actually present because of symptoms from these metastases, not from the lung tumor itself.
Where do they typically spread?
Well, lung cancer can metastasize pretty much anywhere, but the source lists the key common sites and the symptoms they cause. Brain metastases, headaches, nausea, vomiting, seizures, or specific neurologic deficits, depending on the location, very common. Bone metastases, pain, pathologic fractures, breaking with minimal trauma, or spinal cord compression. If Mets are in the vertebrae, that's an emergency. Bone marrow involvement can cause low blood counts. Liver metastases can cause an enlarged liver, hepatomegaly, right upper quadrant pain, fever, anorexia, weight loss. Liver function is usually okay unless it's really widespread. Adrenal gland metastases, also very common, but usually asymptomatic unless they get very large.
That covers direct spread. But then there are these paraneoplastic syndromes. They sound like another major and sometimes really strange way lung cancer can present.
They are really fascinating, often quite dramatic, and sometimes the very first sign that something is wrong, even before the lung tumor is found. They're particularly common with small cell lung cancer, SCLC, but can occur with NSCLC too. They can also be the first sign of recurrence after treatment.
How do they happen?
Sometimes the pathophysiology is known. The tumor itself is secreting a hormone, or a hormone-like substance it shouldn't be. Other times, it's thought to be an autoimmune reaction triggered by the cancer, where the body attacks normal tissues. And successful treatment of the underlying tumor can often make the paraneoplastic syndrome go away.
What are some common examples from the source?
Well, there are systemic syndromes of unknown cause. Anorexia, cachexia, severe wasting, weight loss, losing more than 10% of body weight is a bad prognostic sign. Fever, suppressed immunity. Then endocrine syndromes, maybe 12% of patients. Hypercalcemia, high blood calcium is the most common life-threatening metabolic complication, usually from the tumor making PTH or PTH-related peptide, mostly seen with squamous cell. Symptoms are nausea, vomiting, pain, constipation, excessive thirst and urination, confusion.
Wow.
Hyponatremia, low blood sodium, often due to SIADH. Syndrome of inappropriate ADH secretion, where the tumor makes antidiuretic hormone. Can also be due to ANP, atrial natriuretic peptide. Managing this involves fluid restriction, sometimes medications. SIADH usually resolves if the SCLC is treated effectively. Ectopic ACTH secretion, the tumor makes ACTH, usually SCLC or carcinoids. This typically causes electrolyte problems like low potassium rather than the classic Cushing's body shape, because cortisol levels get so incredibly high. Treating the SCLC is key.
Okay, endocrine covered. What about other systems?
Skeletal connective tissue symptoms. Clubbing of the fingers is seen in about 30%, usually NSCLC. Hypertrophic osteoarthropathy, HPO, affects 110%, usually adenocarcinomas. HPO involves painful inflammation of the bone lining, periostitis, often in the long bones, causing tenderness and swelling, and it lights up on a bone scan.
And neurological ones. The source mentions Eaton-Lambert.
Right. Neurolytic myopathic syndromes occur in about 1%, but can be dramatic. Eaton-Lambert myasthenic syndrome, LEMS, is strongly associated with SCLC. Retinal blindness can also occur with SCLC. Peripheral neuropathies, cerebellar degeneration, cortical degeneration, polymyositis, these can be seen with all lung cancer types. Many are autoimmune, like LEMS, which involves antibodies against voltage-gated calcium channels.
How does Eaton-Lambert present?
It causes proximal muscle weakness, mostly in the legs. Patients might have trouble climbing stairs or getting up from a chair. Autonomic dysfunction can happen too. A key feature is that muscle strength actually improves with repeated effort, which is different from myasthenia gravis. Deep tendon reflexes are often decreased. Treating the underlying SCLC with chemo is the main treatment and can resolve the neurological issues. There are other SCLC-associated syndromes linked to different antineuronal antibodies, like anti-Hu, causing things like widespread inflammation in the nervous system, encephalomyelitis, sensory neuropathies, cerebellar degeneration, or limbic encephalitis.
Wow. Any others? Blood clots, skin, kidneys?
Yes. Coagulation issues are common, 1 to 8%. Migratory thrombophlebitis, Trousseau syndrome, non-bacterial thrombotic endocarditis, DIC. Having blood clots with cancer is generally a poor prognostic sign. Cutaneous skin manifestations are uncommon, 1%, like dermatomyositis or acanthosis nigricans. Renal kidney issues are also rare, 31%, like nephrotic syndrome or glomerulonephritis.
That's an incredibly varied list. It really highlights how lung cancer can affect almost any part of the body, sometimes in really unexpected ways. The source provides tables summarizing these common symptoms and signs, which really drives home the need for a thorough history and physical exam. Okay, so given this huge range of possible presentations, how is lung cancer definitively diagnosed? Getting tissue seems absolutely critical.
It is absolutely required. Tissue sampling is needed for confirmation in all suspected cases. Imaging can raise suspicion, but you need pathology. And an important point, if metastatic disease is suspected based on imaging, biopsy of a distant accessible site, like liver, bone, lymph node, is often preferred.
Why biopsy the metastasis first?
Because if that biopsy confirms cancer, it immediately establishes the patient has stage 4 disease, which fundamentally changes the treatment plan, often avoiding the need for more invasive procedures in the chest. And the source emphasizes, again, a core biopsy, which gets a slightly larger piece of tissue, is preferred over just fine needle aspiration, FNA, especially for NSCLC.
Why the core biopsy preference?
To ensure you get enough tissue for all the necessary testing today. Not just the basic microscopic diagnosis, but the extensive molecular profiling, like NGS, and the PD-L1 testing that are essential to guide modern, personalized therapy choices.
Makes sense. What are the main methods for getting that tissue?
There are several minimally invasive techniques. Fiber optic bronchoscopy allows doctors to look into the airways and take direct biopsies, bronchial biopsy, or pass instruments through the airway wall, transbronchial biopsy. Image-guided biopsy is also common, using CT or ultrasound to guide a needle through the skin, percutaneous biopsy, into a peripheral lung mass or a metastatic site. And specialized ultrasound techniques like EVUS, endobronchial ultrasound, and EUS, endoscopic ultrasound through the esophagus, allow guided needle biopsies of lymph nodes in the mediastinum, the central chest area.
What about lymph nodes specifically?
Yeah, sampling lymph nodes is crucial for staging. EBS and EUS are the main minimally invasive ways now. Blind biopsies might be done depending on location. For suspected metastatic disease, confirmation can come from any of these biopsy methods targeting a suspicious site, soft tissue, bone marrow, liver, pleura. If there's fluid around the lung, pleural effusion that looks suspicious, draining some fluid, thoracentesis, and sending it for cytology can provide a diagnosis. If it's negative the first time, but suspicion is high, the source says a repeat thoracentesis is warranted. Most malignant effusions are exudative and often bloody, but sometimes they can be caused by infection, peritonitic.
What determines how likely these methods are to get a diagnosis?
The diagnostic yield, it depends on the tumor's location, size, type, and critically, the technical expertise of the person doing the procedure, the bronchoscopist or interventional radiologist, and the pathologist reading the sample. Generally, central lesions like squamous cell or SCLC are often easier to reach via bronchoscopy. Peripheral lesions like adenocarcinomas or large cell might be better candidates for transthoracic needle biopsy.
The source also mentions sputum cytology. Is that still used much?
It's mentioned, yeah. It's inexpensive and non-invasive, just coughing up sputum. But its yield is generally lower because of issues with cell preservation and specimen variability. The yield is highest for larger central tumors like squamous or SCLC. Specificity is high if they see cancer cells. It's almost certainly cancer. But sensitivity is lower, maybe less than 70%, meaning it misses cancers more often. Accuracy improves if you analyze multiple specimens, like 3 samples. The main limitation now, though, is that sputum cytology often doesn't provide enough cellular material or the right type of material, like a tissue block, for the detailed subclassification, PD-L1 testing, and molecular testing that are so important today.
So biopsy is really the standard now for getting enough info. Okay, tissue obtained, diagnosis confirmed. The next critical step is staging, determining the extent of the cancer. The source details 2 essential parts to staging.
That's right. It breaks it down into anatomic staging, which is figuring out exactly where the tumor is located and if and where it has spread, TNM staging, and physiologic staging, which is assessing the patient's overall health and their ability to actually tolerate the potential treatments. Physiologic staging involves a complete history and physical exam, looking carefully at comorbidities, other health problems, performance status, how active the patient is, and any history of significant weight loss. Staging for surgical resectability mainly applies to NSCLC, as surgery is less often used for SCLC.
Okay, let's focus on the anatomic staging first for NSCLC. What imaging is required according to the source?
The initial radiographic imaging should include a CT scan, a PT scan, or preferably a combined PTC scan. P-scans use a radioactive tracer, usually FDG, a form of glucose, to identify metabolically active tissue. Cancer cells tend to divide rapidly and use a lot of glucose, so they light up on a PET scan as a hotspot.
How is PT used in staging?
It's used both for evaluating the primary tumor and, very importantly, for detecting potential spread to lymph nodes in the chest, mediastinum, and to distant sites, metastases, particularly for nodules bigger than about 1.5 centimeters. The source states that combined 18F FDG PTCT significantly improves staging accuracy compared to doing PT and CT scans separately or just using one alone. It's considered superior for identifying pathologically enlarged mediastinal lymph nodes and detecting extrathoracic metastases. An SUV, or standardized uptake value, greater than 2.5 on PAD is generally considered highly suspicious for malignancy.
Are there limitations to PTNAs?
Yes. Important caveats are mentioned. False negatives can occur. The scan might miss cancer in patients with diabetes. High blood sugar competes with the tracer. With very small lesions under 8 millimeter, or with slow-growing tumors like carcinoids or some well-differentiated adenocarcinomas. False positives can also happen, things lighting up that aren't cancer, commonly due to infections or inflammation, like tuberculosis or fungal infections. So the crucial point the source makes is that PAT should never be used alone for diagnosis or staging. Tissue confirmation of suspicious findings is always required before making treatment decisions.
What about brain metastases?
For checking the brain, MRI is the most effective method. The source notes MRI can also be helpful in specific situations like evaluating superior sulcus, Pancoast tumors, near the brachial plexus, but it's not generally a major part of routine NSCLC staging beyond checking the brain.
The source lists specific findings that would generally rule out curative surgery for NSCLC. What are those?
Yes, these are key contraindications, indicating the disease is too advanced or widespread for surgery to be curative. They include extrathoracic metastases, spread outside the chest, SVC syndrome, paralysis of a vocal cord, indicating nerve involvement high in the chest, most cases of phrenic nerve paralysis, a malignant pleural effusion, cancer cells in the fluid around the lung, cardiac tamponade, fluid around the heart caused by cancer, tumor growing within 2 centimeters of the carina where the trachea splits, unless it's going to be treated with chemoradiotherapy first, metastases in the opposite lung, metastases in contralateral mediastinal lymph nodes and 3-day stones, unless potentially treatable with chemoradiotherapy first or direct involvement of the main pulmonary artery.
So if scans show any of those, surgery is likely off the table.
Generally, yes. But the source stresses that if imaging shows potentially disqualifying findings, tissue confirmation is needed whenever possible. You wouldn't want to deny someone potentially curative treatment based solely on an image that might be a false positive. Beyond imaging, assessing the lymph node status definitively is critical. This often requires minimally invasive biopsy techniques like EBUS or EUS, or sometimes more invasive surgical procedures like mediastinoscopy. The source notes that 25–50% of NSCLC patients have mediastinal node metastases at diagnosis.
When is lymph node sampling recommended?
It's generally recommended if nodes look enlarged on CT or PET scans, if the primary tumor is large, or if it's located centrally in the chest. Knowing the precise nodal status, N0, N1, N2, N3, is absolutely critical for treatment planning, determining whether the best approach is surgery followed by adjuvant chemo, or perhaps combined chemoradiotherapy followed by immunotherapy. The source includes a figure showing the standard IASLC lymph node map and zones, which provides a common language for describing node locations.
Okay, that covers NSCLC staging. How is SCLC staged? Is it the same TNM system?
SCLC staging is a bit different. Current recommendations, according to the source, actually use both the older Veterans Administration, VA 2-stage system, and the standard AJCCUICC 8th edition TNM system.
Why use 2 systems?
The VA system is simpler and historically widely used for treatment stratification in trials. It divides SCLC into just 2 stages. Limited stage disease, LD, is defined as cancer confined to the ipsilateral hemithorax, one side of the chest, that can be encompassed within a tolerable radiation therapy port. This includes things like involvement of lymph nodes above the collarbone on the same side, or contralateral supraclavicular nodes, recurrent laryngeal nerve involvement, or even SVC obstruction. Extensive stage disease, ED, is basically anything beyond that overt metastatic disease seen on imaging or physical exam. This includes things like cardiac tamponade, malignant pleural effusion, or tumor involving both lungs, mainly because these situations can't be included in a single radiation field. Unfortunately, 60–70% of SCLC patients present with extensive stage disease.
And the TNM system for SCLC?
The TNM system is preferred mainly for the rare SCLC patient who presents looking like clinical stage R disease on imaging, as it provides more prognostic detail in that specific subset. For SCLC staging workup, the recommendations include PTCT and an MRI of the brain, because brain metastases are common even in asymptomatic patients, found at about 10%. Bone marrow biopsies are rarely needed anymore due to better imaging detecting mets elsewhere. Confirming metastases uses the same biopsy methods as NSCLC.
What if cancer spreads to the spine?
Right, the source mentions that if spinal cord compression is suspected in any lung cancer patient, SCLC or NSCLC, symptoms like back pain, weakness, paralysis, urinary retention, then a spinal CT or MRI is needed urgently. If mets are found pressing on the cord, consultation with neurosurgery for possible palliative surgery or radiation oncology for palliative radiation is critical. Similarly, if symptoms of leptomeningeal disease develop, cancer spreading to the lining of the brain and spinal cord, MRI of the brain and spine is needed, and a lumbar puncture might be considered. The source notes there's currently no standard approved therapy for leptomeningeal disease from lung cancer.
The source provides those detailed TNM staging tables for NSCLC, table 78-5, 78-6, and a figure showing survival by stage.
Yes, those tables are crucial for understanding the specifics of the TNM system. T describes the primary tumor size and extent of invasion. N describes regional lymph node involvement, noting the specific N1, N2, and N3 locations based on the lymph node map. M describes distant metastasis with M1A, M1B, and M1C categories in the 8th edition reflecting different patterns of spread. For example, T1, T4 are defined by increasing tumor size and invasion into adjacent structures. N status depends on which lymph node stations are involved. M1B means a single distant metastasis in one organ, while M1C means multiple distant metastases. And that figure 78-4 powerfully illustrates the impact. 5-year survival drops dramatically with increasing stage, from 97% for stage IA1 down to essentially 0% for stage IVB. Stage is the most powerful prognostic factor.
Okay, that covers the anatomic side. Now, physiologic staging assessing the patient's fitness. Why is this so important?
It's critical because lung cancer patients, particularly smokers, often have significant comorbidities, other health problems like cardiovascular disease or COPD, that directly impact their ability to tolerate aggressive treatments like surgery or combined chemo and radiation. Physiologic staging assesses this fitness.
What does it involve?
It starts with correcting any fixable problems before treatment, like anemia, electrolyte imbalances, infections, or uncontrolled heart issues. Things like chest physical therapy and, crucially, smoking cessation are important for optimizing the patient's condition before surgery. Specific pulmonary function tests, PFTs, are used to guide surgical decisions. The source mentions threshold values, typically needing an FEV1, a measure of forced expiration, greater than 2 liters or 80% predicted to tolerate removing a whole lung, pneumonectomy, and 1.5 liters for removing a lobe, lobectomy. For patients with borderline lung function but a resectable tumor, cardiopulmonary exercise testing, CPT, measuring VO2 max, maximal oxygen consumption, can help refine risk assessment. A very low VO2 max predicts higher postoperative complications.
What if they can't tolerate a lobectomy?
Patients unable to tolerate a standard lobectomy or pneumonectomy based on their lung function might be candidates for more limited resections, like a wedge resection or a segmentectomy, removing just part of a lobe. However, the source notes these generally have higher rates of local recurrence and potentially decreased overall survival compared to lobectomy. Pneumonectomy itself is reserved for central tumors in patients with excellent lung function.
And heart risks.
Cardiovascular risk is also formally assessed using standard guidelines. A recent heart attack within 3 months is generally considered a contraindication to major thoracic surgery due to a very high risk of dying from another heart attack, around 20%. A heart attack in the past 6 months is a relative contraindication. Other major contraindications listed include uncontrolled heart rhythm problems, severely impaired lung function, FEV11L, high carbon dioxide levels at rest, PCO2 45 mmHg, severely reduced gas exchange, DLCO 40%, or severe pulmonary hypertension.
This really illustrates that staging is far more than just mapping the tumor. It's fundamentally about understanding the whole patient, their cancer, and their overall health to determine the best, safest course of action. Okay, our source now shifts focus directly to treatment strategies, starting with non-small cell lung cancer, NSCLC. It provides an algorithm, figures 78-5. What are the main approaches outlined?
Right, treatment is highly stage dependent. That figure 78-5 gives a nice overview of the general flow based on the initial clinical evaluation, the results of staging, PTCT, maybe brain MRI, the physiological assessment we just discussed, and of course the specific biopsy findings, including histology and molecular markers.
Let's start with the very earliest stages, occult cancer and stage 0.
Occult cancer is when malignant cells are found, say, in sputum or bronchial washings. But imaging like CT scans is actually normal. The stage is TX. These patients have an increased risk of developing detectable cancer later. The challenge is finding the lesion. It usually requires meticulous bronchoscopy with detailed brushings and biopsies. If the lesion can be localized, surgical resection improves survival compared to doing nothing. But close follow-up is crucial because these patients have a very high risk of developing second primary lung cancers later, maybe 5% per year. Stage 0 is carcinoma in situ, basically severe dysplasia confined to the very top layer of cells. Treatment is usually local excision, maybe photodynamics therapy via bronchoscope.
What about those common findings on CT scans now, especially with screening solitary pulmonary nodules, SPNs, and ground glass opacities, GGOs?
Sure.
How does the source say they should be managed?
Right, these are frequent dilemmas. An SPN is defined as a circumscribed density or spot, usually 1 to 6 centimeters, completely surrounded by lung tissue. The management approach, outlined in another algorithm, figure 78-6, is based on estimating the probability that the nodule is actually cancerous, table 78-7. This probability depends on factors like the patient's smoking history, age, and specific features of the nodule on the CT scan, size, margins, calcification pattern.
What factors increase risk?
Table 78-7 lists key variables. Larger diameter, 2.3 centimeters high risk, older age 60, current heavy smoking, never quitting smoking, and spiculated spiky margins are all high-risk features. Smooth margins, younger age, never smoking, or low risk. Comparing the nodule to any available old scans is absolutely crucial. If it hasn't grown in over 2 years, it's almost certainly benign. Specific patterns of calcification, like dent central, popcorn, also strongly suggest benignity. Malignant signs include large size, irregular or no calcification, associated symptoms, growth compared to old scans, or being hot on a PET scan if the nodule is big enough, any 7-8 millimeters for PET to be useful.
So how does probability guide management?
If the estimated probability of cancer is low, say 10%, the usual approach is watchful waiting with serial high-resolution CT scans over time, for example, at 3, 6, 9, 12, 18, 24 months, to ensure stability. If the probability is intermediate, maybe 10, 60%, further testing might be needed, like PT, contrast-enhanced CT, or potentially a biopsy, FNA or bronchoscopy, or sometimes proceeding directly to surgery, depending on the exact risk and patient preference. If the probability is high, 60%, surgery is usually recommended, often using minimally invasive VATS, video-assisted thoracic surgery, with a frozen section done during the operation. If it's confirmed malignant, a formal lobectomy is typically performed.
In ground glass opacities, GGOs, those hazy spots.
GGOs are small, hazy areas seen on sensitive CTs. They can represent a spectrum from precancerous lesions like atypical adenomatous hyperplasia, AAH, usually 5 millimeter hazy non-solid, to adenocarcinoma in situ, AAS still non-solid but maybe slightly denser, to minimally invasive adenocarcinoma, MIA mainly non-solid but with a small central solid component, 5 millimeter. The source notes there can be overlap in the imaging features between these pre-invasive or minimally invasive lesions and small, early invasive adenocarcinomas with a lipidic pattern. Management depends on size, stability, and presence of solid components, often involving surveillance or resection.
Okay. Now, for confirmed stages IN2 NSCLC cancer confined to the lung or maybe nearby hilar lymph nodes, N1 but not mediastinal nodes, N2, N3, surgery seems to be the main treatment when possible?
Yes, absolutely. Surgical resection by an experienced thoracic surgeon is the preferred curative treatment for patients with clinical stage I or E NSCLC, provided they are physiologically fit enough to tolerate the operation. The source notes that outcomes, like operative mortality and long-term survival, tend to be better at high-volume centers that do a lot of these operations.
What type of surgery is standard?
Lobectomy, removing the entire lobe containing the tumor, is considered the standard type of resection. Randomized trials showed it was superior to more limited resections, like wedge or segmentectomy, in terms of reducing local recurrence, with a trend towards improved overall survival as well. However, limited resections, possibly done via VATS, are considered reasonable options for patients with significant comorbidities, compromised pulmonary reserve, or very small peripheral tumors. Pneumonectomy, removing the whole lung, is reserved for more central tumors in patients with excellent lung reserve.
What are the survival rates like for these early stages after surgery?
They're actually quite good, relatively speaking. The source quotes 5-year survival rates ranging from about 68-92% for stage I disease and 53-60% for stage 2 disease. Early detection really matters here.
What about lymph nodes during surgery?
Accurate pathologic staging after surgery requires adequate lymph node sampling or dissection checking nodes along the airway, segmental, at the lung root, hilar, and in the mediastinum. Ideally, the source suggests a complete mediastinal lymph node dissection is performed, detailing the specific nodal stations that should be removed on the right and left sides, plus Hilaroges. A pooled analysis mentioned showed superior 4-year survival with complete dissection compared to just sampling in stages I to A, with little added morbidity when done by experienced surgeons.
Is radiation therapy used after surgery in these early stages?
Generally, no. The source states there's currently no established role for postoperative radiation therapy after a complete resection of stage 1 or 2 NSCLC if the surgical margins are negative, no cancer cells left at the edge.
What if a patient can't have surgery for stage 3 disease?
Right, for patients who are medically inoperable or refuse surgery for stage 3 NSCLC, radiation therapy with curative intent is a very important option. A technique called stereotactic body radiation therapy, SBRT, sometimes called AFBR, has become prominent. It's specifically for isolated pulmonary nodules, usually A5 centimeters, in non-surgical candidates. It delivers very high ablative doses of radiation very precisely to the tumor over just a few treatment sessions, typically 1 to 2 weeks. Uncontrolled studies cited show excellent local disease control rates with SBRT, over 90%, and 5-year survival rates up to 60%, in selected patients significantly better than what was achieved with older, standard external beam radiation techniques, which had survivals more like 13 to 39%. Cryoablation, freezing the tumor, as mentioned, is another technique for small tumors, but with less long-term data available compared to SBRT.
Okay, so SBRT is a key option for non-surgical candidates. What about chemotherapy in stage 1 and 2? Is it used?
Adjuvant chemotherapy, meaning chemo given after potentially curative surgery, was evaluated in a large meta-analysis called LC. This looked at trials using cisplatin-based chemo in patients with resected stage I through AL3A NSCLC. Overall, LT showed a modest but statistically significant improvement in 5-year survival, about 5.4% for patients who received adjuvant chemo compared to surgery alone.
A 5% absolute benefit. Is that for everyone?
Here's a critical nuance from LDCT highlighted in the source. The benefit seemed confined primarily to patients with stage 2 and stage 3 disease. In fact, survival appeared to be worsened in patients with stage IA disease who received adjuvant chemo, and the benefit in stage IB was only modest or questionable. It was also detrimental in patients with poor performance status, ECOGS PS2.
So adjuvant chemo is mainly for stage 3, not stage 1.
That's the general recommendation based on LOD, yeah. Adjuvant chemo is best applied in completely resected stage 2, or I2IA NSCLC. There's generally no role and potentially harm in stage IA, and questionable benefit in most stage IB. There's one exception noted in the source, the EGFR inhibitor drug osimertinib. The ADAR trial showed significantly improved disease-free survival, DFS time, until recurrence, when osimertinib was given for 3 years after standard adjuvant chemo or instead of chemo in some stage IB, for patients with resected stage IB, tumors 4 centimeter, or I3A NSCLC that has specific EGFR mutations.
Does it improve overall survival too?
The source text notes that the effect on overall survival, OS, from I to RO was unknown within the main chapter text at the time of writing, though the further reading list might point to updated results. Based only on the core text, osimertinib is mentioned for improving DFS post-chemo in this specific EGFR-mutated early-stage setting.
Okay. So if standard adjuvant chemo is used, mainly for stage 3, how is it given?
It should typically start within 6-12 weeks after surgery, once the patient has recovered sufficiently. It's usually given for no more than 4 cycles. Cisplatin-based regimens are preferred based on trial data, but carboplatin can be substituted for patients who might not tolerate cisplatin well due to kidney issues, neuropathy, hearing loss. Trials haven't shown a significant survival difference among the commonly tested partner drugs used with platinum, like Zenorelbine, Pemetrex, Gemcitabine, Docetaxel, so the choice often considers cost, potential side effects, and the patient's other health conditions. Adding anti-angiogenic drugs didn't seem to help in the adjuvant setting.
What about giving chemo before surgery, neoadjuvant chemo?
Neoadjuvant chemo is also discussed. Some experts advocate for it, hoping to shrink the tumor, potentially making surgery easier or making borderline resectable tumors clearly resectable. A meta-analysis of 15 trials looking at stages 4 suggested a modest 5-year survival benefit, around 5%, similar in magnitude to adjuvant chemo. So the source includes it may be useful in selected cases, but the decision should always be made in consultation with an experienced thoracic surgeon. It's not routine for all early stages.
Okay, and after treatment for stage 3, what's the recommended follow-up?
Patients who have had surgery for NSCLC remain at high risk for recurrence of the original cancer or for developing a second new primary lung cancer. Most recurrences happen within the first 18-24 months, so periodic imaging is considered reasonable. Based on the NLST results showing CT's effectiveness, CT scans seem most appropriate for surveillance. Some guidelines suggest getting a contrast-enhanced chest CT every 6 months for the first 3 years, and then switching to yearly non-contrast CT scans after that.
Got it. Now let's move into the complexities of stage 3 NSCLC. The source describes this as locally advanced and requiring a multidisciplinary approach.
Absolutely. Stage 3 is really heterogeneous. It covers a wide range of T and N combinations, so there's no single one-size-fits-all approach. Treatment decisions are complex and often debated. Key factors guiding the choices include the specific combination of T stage, tumor size invasion, and N stage, nodal involvement, the likelihood of achieving a complete surgical resection, and the patient's overall fitness physiologic stage.
How is stage IIA typically approached? The source mentions bulky versus non-bulky nodes.
Right. Stage IPA often involves mediastinal lymph nodes on the same side as the tumor, N2 nodes. It's often stratified based on whether this N2 involvement is considered non-bulky versus bulky. The definition of bulky can vary a bit, but generally it implies large nodes, maybe 2-3 centimeters, multiple smaller nodes clumped together, signs of cancer extending beyond the node capsule, or involvement of multiple nodal stations. This distinction helps select potential candidates for upfront surgery, perhaps followed by chemo, versus those who are better treated with neoadjuvant therapy, chemo or chemo-T, before considering surgery, or those who should go straight to definitive chemoradiotherapy.
Okay, let's look at specific stage 3 scenarios outlined in the source. What if N2 nodes are found unexpectedly after surgery for presumed stage 3?
That's called pathologic N2 disease. In that situation, where the N2 nodes weren't known beforehand, surgery has already been done. The standard approach then is adjuvant postoperative chemotherapy. Postoperative radiation therapy, PRT, may also have a role in this setting, particularly if surgical margins were positive or very close.
What about tumors that are large or invasive, T3, T4, but only have N1 nodes, Heller, or no node involvement, N0? Still stage 3, right?
Yes. For example, a T3N1 tumor, maybe 7 centimeters, or invading the chest wall or main airway close to the carina with only Heller N1 nodes but no N2, is generally best managed with surgery if feasible, followed by adjuvant chemo if completely resected. T3N0 or T3N1 disease due to satellite nodules in the same lobe as the primary tumor are also usually surgical candidates. T4N0 or T4N1 disease, like separate tumor nodules in a different lobe on the same side but with negative mediastinal nodes, are also considered potential surgical candidates. Adjuvant chemo is often recommended for these T3, T4 subsets too, although data might be more limited.
What if a T4 tumor invades critical structures?
T4 and 01 can involve things like the carina, the SVC, or vertebral bodies. Surgery might be feasible in highly selected cases, requiring a specialized multidisciplinary team, thoracic surgeon plus maybe vascular, cardiac, or orthopedic surgeons. However, the source is clear. If a complete resection isn't deemed possible, or if there's also N2 involvement, which would make it stage IIB anyway, surgery for T4 disease is generally contraindicated. Most T4 lesions end up being treated with concurrent chemoradiotherapy, now typically followed by immunotherapy consolidation with durvalumab.
Is PORT postoperative radiation always used after surgery in stage 3? You mentioned it might have a role if N2 nodes are found pathologically.
No, PORT, after a complete resection of stage 3 NSCLC, is controversial, and its use depends largely on the N status. Meta-analyses mentioned in the source, using large databases like SEER and results from the PORT meta-analysis trialist group, identified a significant survival increase with PORT, specifically in patients with pathologically confirmed N2 disease. However, these analyses showed no survival benefit and potentially even harm from PORT in patients with N0 or N1 disease after complete resection. So it's mainly considered for positive N2 nodes.
Okay, what if N2 or N3 nodes are known before treatment starts, documented preoperatively?
If mediastinal N2 or N3 nodes are known up front, a combined modality approach is generally recommended if the patient is potentially curable. Surgery alone in this setting leads to very high rates of both local and distant recurrence. The standard initial treatment for unresectable stage 3 NSCLC, which includes most N3 and bulky N2 disease and many T4 tumors, is concurrent chemoradiotherapy, followed by consolidation immunotherapy with durvalumab for up to a year, based on the Pacific trial.
Concurrent versus sequential chemort.
Concurrent chemort, giving both treatments together, has been shown to be superior to sequential chemo, followed by inflammation of the esophagus, esophagitis, and low blood counts, neutropenia. So concurrent is generally preferred for patients with good performance status who can tolerate it. Sequential might be used for patients with poorer performance status. For those unable to tolerate combined treatment at all, radiation alone can offer modest palliation.
The idea of doing surgery after chemoradiotherapy for stage 3 is also discussed.
Yeah.
Still controversial.
Yes, highly controversial. The source mentions a key NCI trial that directly compared concurrent chemort alone versus concurrent chemort, followed by an attempt at surgical resection. That trial found no overall survival benefit in the arm that got surgery after chemort. In fact, patients who ended up needing a pneumonectomy, removal of the whole lung, after induction therapy actually had worse survival.
So surgery after chemort isn't generally recommended.
Well, a retrospective subset analysis of that trial suggested there might be a survival advantage for surgery if a complete resection could be achieved with only a lobectomy. So the source concludes that surgery after neoadjuvant chemort may be a reasonable option, but only in carefully selected healthy patients with initially non-bulky N2 disease, and only if the tumor can be completely resected with just a lobectomy. It's definitely not recommended if a pneumonectomy would be required.
Okay, very selective use then. What about superior sulcus tumors or Pancoast tumors? The source mentions them as a specific subtype.
Yes, they're treated as a distinct subset of stage 3 disease. These arise right at the apex top of the lung and can invade surrounding structures like ribs, the brachial plexus nerves, blood vessels, the stellate ganglion, part of the sympathetic nervous system, or even the vertebrae. The classic Pancoast syndrome symptoms are shoulder and chest wall pain radiating down the arm in the ulnar distribution, pinky side, often with bone destruction seen on imaging. Horner's syndrome can also be present if the sympathetic nerves are involved.
How are they staged and treated?
Staging is the same T&M system as other NSCLC. For Pancoast tumors that are N0 or N1, no mediastinal node involvement, the standard approach is typically neoadjuvant induction therapy, either chemotherapy alone or combined chemoradiotherapy followed by surgical resection. The source notes that this combined approach can yield excellent 5-year survival rates, over 50%, if a complete R0 resection can be achieved. However, patients with Pancoast tumors who also have N2 disease are much less likely to benefit from surgery and are usually managed definitively with chemoradiotherapy, likely followed by durvalumab consolidation, similar to other unresectable stage 3 disease. Metastatic Pancoast tumors receive palliative systemic therapy and the Pandor radiation.
Got it. Now let's tackle the most common scenario at diagnosis, metastatic NSCLC stage 4. The source states around 40% of patients already have stage 4 disease when first diagnosed. What's the overall approach here?
Right, and many patients initially diagnosed with earlier stages eventually relapse with distant disease too. Interestingly, those who relapse after initial curative treatment tend to have a somewhat better prognosis than those who present with stage VA disease right from the start. For stage 4, the cornerstone of management is standard medical care, good pain and symptom control, appropriate use of radiotherapy for palliative purposes, like treating painful bone mets or brain mets, and systemic therapy.
What are the systemic therapy options now? It sounds like this has changed a lot.
It really has. The main options are targeted therapy, immunotherapy, and traditional cytotoxic chemotherapy. The choice depends critically on the specific diagnosis, histology, the tumor's PD-L1 expression level, tumor proportion score or TPS, and, most importantly, the tumor's molecular subtype, whether it has specific driver mutations. Systemic therapy in stage V is generally palliative, meaning it aims to control the cancer, relieve symptoms, improve quality of life, and extend survival rather than cure the disease. It's most effective in patients with good performance status.
What about palliative care itself?
That's a key point the source makes. Early integration of specialized palliative care alongside standard oncologic treatment, like chemotherapy or immunotherapy, has been shown in trials to improve not only quality of life but also survival in patients with advanced NSCLC. Aggressive management of pain and other symptoms is vital.
Okay, let's delve into those targeted therapies. The source calls driver mutations the Achilles heels.
This is where molecular profiling has truly revolutionized treatment for a subset of NSCLC patients. For those whose tumors harbor specific oncogenic driver mutations, highly active oral therapies are available that can lead to dramatic responses and significantly improve survival compared to traditional chemotherapy.
Remind us what driver mutations are again.
They're mutations in specific signaling genes that essentially drive the tumor's growth and survival. Targeting the protein products of these mutated genes with small molecule inhibitors is the strategy. Because these targeted therapies can be so effective, the source emphasizes that all patients diagnosed with advanced NSCLC should undergo broad panel-based molecular testing, often using next-generation sequencing, NGS, to identify these potential driver mutations. These tests look for mutations, gene fusions, rearrangements, or deletions in a whole panel of relevant genes, including EGFR, ALK, ROS1, BRAF, REST, MET, NTRK, CRESS, PIK3CA, NRAs, and others. Identifying these is absolutely critical for selecting the optimal first-line therapy.
Okay, let's go through some of the major driver mutations and the targeted therapies, the source details. EGFR.
EGFR mutations are found in about 10-15% of NSCLC cases in North America, more common in Asia. They're strongly associated with patients who are younger, never or light smokers, and have adenocarcinoma histology. About 90% of these are specific mutations, either deletions in exon 19 or a point mutation called L858R and exon 21 within the tyrosine kinase domain of the EGFR gene. These mutations cause the EGFR receptor to be hyperactive. Tumors with these sensitizing mutations are highly sensitive to EGFR tyrosine kinase inhibitors, TKIs.
Which drugs are used?
Approved EGFR TKIs mentioned include osimertinib, erlotinib, gefitinib, afatinib, and baclomitinib. These are all oral pills. The source references numerous phase 3 trials listed in Table 78-9, like IPASS, FLAURA, etc., that consistently show improved response rates and progression-free survival, PFS, with EGFR TKIs, compared to standard chemotherapy as first-line treatment for EGFR mutant NSCLC. Notably, the FLAURA trial showed that osimertinib, a third-generation TKI, was superior in both PFS and overall survival OS compared to earlier-generation TKIs like erlotinib or gefitinib. So osimertinib is often the preferred first-line agent now for common EGFR mutations.
Okay, what about ALK?
ALK fusions or rearrangements occur in about 3-7% of NSCLC cases. These involve the ALK gene on chromosome 2 rearranging and fusing with another gene, leading to constitutive activation of the ALK tyrosine kinase. Similar to EGFR, ALK fusions are typically, though not exclusively, found in younger patients, light or never smokers, with adenocarcinoma histology.
And the drugs.
There are several effective ALK TKIs. Crizotinib was the first generation. Then came second-generation agents like alectinib, brigatinib, and ceritinib, which are now approved for first-line use. Trials like ALEX and ELTA1L, Table 78-A, showed that alectinib and brigatinib provided superior PFS compared to crizotinib. Lorlatinib is a third-generation ALK TKI, approved for patients whose cancer progresses on a second-generation drug. Testing for ALK can be done by a FISH, IHC, or NGS.
RS1, NTRK.
RS1 fusions are less common, around 1%, detected by FISH or NGS. They share similarities with EG-FREL mutations, often in younger light never smokers. Crizotinib, lorlatinib, which inhibit both ALK and RS1, and another drug called entrectinib are approved therapies. NTRK fusions are even rarer, less than 1%. These involve the NTRK1, 2, or 3 genes fusing with other partners, causing constitutive TRK kinase activation. Interestingly, while more common in never smokers, they can occur in older patients compared to RS1 ALK. 2 drugs, entrectinib and larotrectinib, showed impressive and durable efficacy across various tumor types with NTRK fusions, not just lung, and are approved. This is a great example of tumor-agnostic therapy based on the mutation, not the location.
What about MET?
MET exon 14 skipping mutations are found in about 3-5% of NSCLCs. Unlike the others we just discussed, these can be seen in both squamous and non-squamous histologies, and also occur in patients with a significant smoking history. Pharmacologic inhibition with specific IMiD inhibitors like capmatinib or tepotinib showed high response rates, over 70% in some studies, especially in treatment-naive patients.
BRAF.
BRAF mutations occur in about 2% of NSCLCs. Again in both squamous and non-squamous, and with roughly equal prevalence in smokers and non-smokers. The most common is the V600E mutation. Combined BRA plus ME inhibition using dabrafenib plus trametinib is an approved first-line or later option for BRAF V600E mutant NSCLC, shown to be superior to using a BRAF inhibitor alone. RET alterations, usually chromosomal rearrangements causing constitutive AT kinase activation, are found in about 1%. Detected by FISH or NGS. A targeted drug, selpercatinib, showed excellent response rates, around 85% in treatment-naive patients with RET-altered NSCLC. Pralsetinib is another option.
That's a lot of specific targets and drugs. The source includes a figure summarizing these.
Yes. Figure 78-7 provides a great overview summarizing these key targetable driver alterations and the potential therapies supported by guidelines like the NCCN. It really illustrates the complexity and the promise of this molecularly targeted approach.
What about KRAS? That's a common mutation, right?
KRAS mutations are very common, found in about 20% of lung adenocarcinomas. For a long time, they were considered undruggable. However, agents specifically targeting one common KRAS mutation, G12C, like sotorasib and adagrasib, have now been developed and shown activity, marking a major breakthrough. Most other potential driver mutations are individually rare, maybe 1-3% or less. And remember that key point. Most of these driver mutations are mutually exclusive. A tumor usually relies on just one main driver. Understanding how resistance develops to these TKIs is now a major area of research.
Okay, so targeted therapies are huge for patients with those specific mutations. But what about the majority who don't have one of those targetable drivers? Immunotherapy seems to be the other major advance.
Absolutely. Immune checkpoint inhibitors have significantly improved outcomes, quality of life, and survival, primarily for patients without a targetable genetic lesion. The treatment workflow shown in Figure 78-8 starts with histology, then checks for actionable mutations. If none are found, immunotherapy comes into play.
How do they work again?
They work by blocking inhibitory interactions between immune cells, T cells, and tumor cells or other cells in the tumor environment. Normally, interactions like PD-1 binding to PD-L1 or CTLA-4 signaling act as brakes to prevent excessive immune responses. Cancer cells can exploit these checkpoints to evade immune attack. Checkpoint inhibitor drugs block these interactions, essentially releasing the brakes on the T cells and allowing them to recognize and kill cancer cells more effectively.
Which drugs are used, and how is treatment decided?
Several checkpoint inhibitors are approved for NSCLC, targeting either PD-1 like pembrolizumab, nivolumab, semiflimab, or its ligand PD-L1 like ditsilizumab, durvalumab, or CTLA-4, ipilimumab, usually used in combination. Trials listed in Table 7811 demonstrate superior overall survival with immunotherapy, either as monotherapy like pembrolizumab or atezolizumab, or in combination like nivolumab plus ipilimumab, compared to standard chemotherapy in metastatic NSCLC, particularly when the tumor expresses higher levels of PD-L1, e.g. TPS-U 50% or EL1%.
So PD-L1 level is the key biomarker.
It's the main biomarker used, yes. Figure 7808 provides a clinical approach based on histology, squamous versus non-squamous, and the PD-L1 status, example, 50%, 149%, 1%, for choosing first-line therapy in patients without a driver mutation. This figure illustrates how different immunotherapy regimens, either single-agent immunotherapy for high PD-L1 expressors or combinations of chemotherapy plus immunotherapy for those with lower or no PD-L1 expression, are recommended. However, the source notes PD-L1 is an imperfect biomarker. Some patients with low or negative PD-L1 still respond to immunotherapy, and not all patients with high PD-L1 respond. Research is ongoing to find better biomarkers.
And critically, immunotherapy isn't usually first line if there is a driver mutation.
That's a crucial point emphasized in the source. Patients with driver mutations like EGFR or ALK appear to benefit more from the appropriate targeted therapy than from immunotherapy, even if their PD-L1 expression is high. So TKI therapy should generally be given first in those cases. Research is also actively exploring combining these immunotherapy agents in earlier stages of disease, like in the neoadjuvant setting before surgery, and combining them with chemoradiotherapy for stage 3 disease.
So targeted therapy for drivers, immunotherapy, often with chemo, for non-drivers. Does traditional cytotoxic chemotherapy still play a role on its own?
It's typically used first line in combination with immunotherapy now, unless there's a contraindication to immunotherapy. The choice of chemotherapy agents often differs by histology, as we discussed earlier. Pemetrexed is often preferred with platinum and immunotherapy for non-squamous histology because it improves survival in that group. Gemcitabine, with platinum and immunotherapy, is often used for squamous histology. This difference, again, relates to that enzyme thymidylate synthase, TS. Squamous cancers tend to have much higher TS levels than adenocarcinomas, making them less responsive to pemetrexed, which targets TS. Gemcitabine's activity isn't impacted by TS levels.
What about after progression on first-line therapy, second-line options?
For patients whose cancer progresses after first-line platinum-based therapy, which now usually includes immunotherapy, second-line options are considered. Docetaxel is a standard chemotherapy agent that showed improved survival versus just supportive care in older trials. Adding romucirmab, an antibody targeting the VEGF receptor 2, involved in blood vessel growth, to docetaxel has been shown to improve both PFS and OS compared to docetaxel alone in platinum-pretreated patients. An important point about ramucirmab is that, unlike an older anti-angiogenic drug, bevacizumab, it appears safe to use in both squamous and non-squamous histologies and is approved regardless of histology in the second-line setting with docetaxel.
And finally, supportive care still essential.
Absolutely essential, but sometimes overlooked. The source reiterates the importance of early integration of palliative care alongside standard cancer treatment for stage 5 NSCLC patients. It improves quality of life and overall survival. Aggressive management of pain and other symptoms is vital throughout the course of illness.
Okay, that's a comprehensive overview of NSCLC treatment. Now let's shift to small cell lung cancer, SCLC. It's presented as a highly aggressive disease. How does treatment differ? The source provides a separate treatment algorithm, 78 to 9.
SCLC behaves very differently from NSCLC. It's characterized by extremely rapid doubling time, a high growth fraction, meaning lots of cells are actively dividing, a strong tendency for early dissemination, metastasis, and often a dramatic initial response to chemotherapy and radiation. However, despite that initial sensitivity, relapse is unfortunately very common, and the disease often becomes resistant to further treatment.
Is surgery ever used for SCLC?
Not routinely, no. Because SCLC tends to have occult micrometastases, tiny hidden spread, even when it appears localized, SCLC, surgery is generally not recommended as the primary treatment. However, the source mentions an exception based on guidelines from the American College of Chest Physicians. For the very rare patient who presents with clinical stage SCLC, a small isolated tumor with no nodal involvement, after a thorough evaluation rules out distant mets and includes invasive mediastinal staging. In that specific scenario, surgery is recommended over non-surgical treatment. These patients would then receive platinum-based adjuvant chemotherapy after resection. Similarly, if SCLC is found incidentally in a surgical specimen removed for what was thought to be NSCLC, they would also get standard SCLC chemotherapy afterwards. But these are rare situations.
So for most SCLC, chemotherapy is the mainstay. What's the standard approach for limited stage LD disease?
For decades, the standard for LD-SCLC has been concurrent chemoradiotherapy, giving chemotherapy and radiation therapy together. The standard chemo regimen has been cisplatin plus etoposide, usually for 4 cycles.
Has that changed recently, like with NSCLC immunotherapy?
Yes, combination with PD-L1 inhibitors is changing the landscape here too, though more prominently established first in extensive stage disease. For extensive stage SCLC, randomized phase 3 trials, Empower 133 using atezolizumab and Caspian using durvalumab, showed superior PFS and OS when platinum etoposide chemo was combined with one of these immune checkpoint inhibitors compared to chemo alone. This chemo-immunotherapy combination is now the preferred first-line standard for extensive stage SCLC. Its role in limited stage is still evolving, but often incorporated.
What are the outcomes like, even with these newer approaches?
Despite high initial response rates, up to 80% respond to first-line therapy, the median survival is still unfortunately limited. For LDSCLC, it's in the range of 12-20 months. For EDSCLC, it's closer to 12 months on average. Most patients eventually relapse and the disease becomes chemo-resistant.
What happens at relapse?
Prognosis is particularly poor if the cancer relapses within 3 months of finishing initial chemo. This is considered chemotherapy-resistant disease. Patients who relapse later, say more than 3 months after finishing, considered sensitive disease, have a better chance of benefiting from second-line chemotherapy. Second-line agents generally have lower activity than first-line. Options mentioned include topotecan, given IV orally tends to work better in sensitive relapse, and a newer drug, lurbinectedin, which showed about a 35% response rate and median PFS of 3.5 months in trials, also generally better in sensitive relapse. Other agents with low activity that might be tried include irinotecan, paclitaxel, docetaxel, vinorelbine, oral etoposide, or gemcitabine.
Thoracic radiation therapy, TRT, is also a key part of LD-SCLC treatment you mentioned concurrently.
Yes. TRT is a standard component of the initial curative intent therapy for LD-SCLC in patients with good performance status. Meta-analyses clearly show that adding chest irradiation to chemotherapy improves 3-year survival by about 5% compared to chemo alone. However, even with chemo, the 5-year survival remains low, around 10-15%. TRT is usually combined with cisplatin and etoposide, as this regimen has a better toxicity profile when combined with radiation compared to older anthracycline-based regimens. And like we saw with locally advanced NSCLC, giving chemo and radiation concurrently is more effective than giving them sequentially, chemo first, then radiation. But it does come with higher rates of side effects like esophagitis and hematologic toxicity.
When should the radiation be given?
Ideally, the source suggests, TRT is given concurrently starting with the first or second cycle of chemotherapy. Delaying it seems less effective. If concurrent treatment is impossible due to fitness or logistical issues, it typically follows induction chemotherapy. There's also discussion about the optimal radiation dose and fractionation. A commonly used standard regimen involves giving 1.5 gray fractions twice daily for 30 days, totaling 45 TA. This showed improved survival compared to once daily radiation in one trial, but with higher rates of severe esophagitis and lung toxicity. Delivering higher doses, up to 70 GJ, concurrently once daily is feasible, but the source notes no definitive data yet supporting its equivalency to the 45 GG twice daily standard. Trials comparing these are ongoing. Patient selection is key for concurrent chemotherapy needing good performance status and adequate pulmonary reserve.
Does radiation have a role in extensive stage SCLC?
In ED-SCLC, the role of thoracic radiate is mainly for symptom palliation, for example, treating painful bone metastases or relieving bronchial obstruction caused by the tumor. It's not typically used curatively in the extensive setting.
Okay, finally for SCLC, what about prophylactic cranial irradiation, PCI? Radiation to the brain even if there are no known mets there.
Right. PCI should be considered for patients with LD-SCLC who achieve a good response, complete or near complete remission, after their initial chemoradiotherapy. It should also be considered for ED-SCLC patients who have responded well to initial chemo plus immunotherapy. However, its routine use in all ED-SCLC responders is more controversial.
Why is it done? Does it improve survival?
The brain is a common site for SCLC to metastasize, and chemotherapy doesn't penetrate the blood-brain barrier very well. PCI aims to eradicate microscopic brain metastases before they become clinically apparent. A meta-analysis in LD-SCLC patients who were complete responders showed PCI provided a modest 5.4% improvement in overall survival. In ED-SCLC responders without known CNS disease, while observation led to a higher incidence of brain metastases appearing later, PCI did not clearly improve overall survival in that setting in a key trial.
Are there downsides to PCI?
Yes, potential long-term toxicities are a concern, particularly cognitive deficits, memory problems, slowed thinking. However, the source notes it can be hard to definitively separate these effects from the cognitive effects of chemotherapy itself or just normal aging. It's a trade-off discussion with the patient.
Okay, that covers SCLC. Our source then briefly covers thymic tumors. They're quite rare.
Very rare, yeah. Thymomas and thymic carcinomas make up only about 1.5% of all cancers in the U.S., though the incidence is noted to be higher in Asian populations. They're rare in children and young adults, typically peaking in the 50s. No clear sex difference or established risk factors.
Where do they occur?
Most occur in the anterior mediastinum, the space in the front of the chest behind the sternum where the thymus gland sits. About 40% of masses found in that location turn out to be thymic tumors. The source notes that if an anterior mediastinal mass is suspected, blood tests for HCG and phenylephrine should be done first to rule out a germ cell tumor, which can also occur there.
How do thymic tumors present?
Clinically, they can cause symptoms due to local pressure on organs, things like chest pain, shortness of breath, cough, or even SVC syndrome if they compress the superior vena cava. Or, interestingly, they can present because of associated paraneoplastic syndromes. The most common one by far is myasthenia gravis, an autoimmune neuromuscular disease.
Oh.
Others mentioned include pure red cell aplasia, a type of anemia, and hypogammaglobulinemia, low antibody levels. Rarer autoimmune syndromes can also occur.
How are they staged and treated?
Staging involves CT chest with contrast to assess resectability. MRI might be used sometimes. PET scans can be useful, but maybe less so for thymoma compared to the more aggressive thymic carcinoma. A core needle biopsy is the standard way to get a diagnosis, but sometimes surgical biopsy is needed. Staging systems include the Masaoka system, based on invasion and spread, and the WHO classification, based on histology cell type, ranging from well-differentiated types AAB1 to poorly differentiated type C thymic carcinoma. Treatment really hinges on stage. Surgery is the mainstay for early stage encapsulated tumors, Masaoka 3. For a potentially resectable but more invasive stage 3 disease, neoadjuvant chemotherapy might be used first to try and shrink the tumor to allow for a complete resection. The role of surgery for clearly unresectable stage 3 is limited. Postoperative radiation, CORT, is often recommended after surgery for more invasive stages like 2 or 3 or specific WHO types, B3C, especially if there is invasion beyond the capsule or positive surgical margins. Radiation can also palliate symptoms from locally advanced disease.
Chemotherapy regimens like CAP, cisplatin, doxorubicin, cyclophosphamide are used for neoadjuvant settings or metastatic thymoma. Carboplatin paclitaxel is often used for thymic carcinoma. Options for second-line therapy are limited due to the rarity of the disease. Multidisciplinary team evaluation is key.
Okay, a rare but distinct entity. Finally, our source concludes with a brief but obviously important section on the impact of the COVID-19 pandemic on lung cancer patients.
Yes, this was a major recent challenge for everyone, but particularly for cancer patients. COVID-19, the respiratory infection caused by SARS-CoV-2. Large data sets quickly showed that patients with cancer, and especially those with lung cancer, had an increased risk of severe morbidity and mortality if they got infected.
Why lung cancer patients specifically?
likely due to underlying lung damage from smoking or the cancer itself, older age, other comorbidities, and potentially immunosuppression from the cancer or its treatments. A significant challenge for healthcare providers during the pandemic was distinguishing the symptoms and radiographic findings of COVID-19 pneumonia, or pneumonitis, from those caused by the lung cancer itself, or from treatment side effects like radiation pneumonitis or immune-related pneumonitis from immunotherapy. They could look very similar on scans.
And the outcomes were worse.
Yes, high mortality rates, unfortunately, were reported for lung cancer patients who contracted SARS-CoV-2 infection, with some studies citing rates up to 35%. The source identifies specific risk factors associated with higher mortality if a lung cancer patient got infected. Older age, 65, worse performance status, ECOG PS1, being on significant doses of glucocorticoids, like 2 milligrams of prednisone, being on anticoagulation, and having received chemotherapy within 3 months of the COVID diagnosis.
What about the long-term impact of the pandemic on lung cancer care overall?
That's a crucial concern raised at the end. The pandemic caused significant disruptions to healthcare worldwide, leading to delays in cancer screening, diagnosis, and treatment initiation or continuation. The source expresses concern that the long-term impact of these delays on overall lung cancer mortality is likely to be felt for years to come, potentially reversing some of the progress made in recent decades.
A sobering final point. Wow, that really was a deep dive into Chapter 78. We've covered an incredible amount of ground, from the history and the profound link to smoking and other risk factors, to the critical role of pathology in molecular classification, the game-changing but complex data around LDCT screening, the incredibly varied clinical presentations, including those tricky paraneoplastic syndromes, the vital role of tissue biopsy and detailed staging, both anatomic and physiologic, and then the rapidly evolving treatment landscapes for both NSCLC, with its huge shift towards personalized, targeted, and immunotherapy approaches, and SCIC with its chemotherapy focus and the roles of radiation and PCI. We also managed to touch on those rare thymic tumors and the recent significant challenge of the COVID-19 pandemic's impact. It feels like we've really tried to master this chapter, like the brief asked.
We definitely covered the key areas. We've seen how understanding those molecular drivers offers powerful new therapeutic targets, those Achilles heels. We've seen how the complex staging systems guide absolutely critical treatment decisions, and how multimodal therapy combining surgery, radiation, chemo, targeted therapy, immunotherapy is often required, especially for more advanced disease. And we also saw the significant challenges that remain, particularly the problem of treatment resistance and ensuring appropriate patient selection for these increasingly complex therapies and for screening programs.
It's really clear this field is incredibly dynamic. There have been major advancements in diagnosis and treatment leading to real improvements in survival, which is great news. Yet, obviously, much more research is still needed.
Indeed. As the chapter summary notes, advances in understanding tumor biology, genetics, and immunology have been absolutely key to the progress we've seen. But overcoming resistance mechanisms and finding ways to extend the benefits of these novel therapies to more patients, those are major ongoing priorities that continue to drive clinical trials and research in the field. Mastering this complex information is really key to navigating it all.
Well, for you listening, hopefully this deep dive into Chapter 78 has provided you with a solid foundation. Hopefully it's clarified key concepts and highlighted the most important details you need to be well informed on neoplasms of the lung.
What stands out most to you from this deep dive we just did? Maybe it's the dramatic historical shift of the disease from rarity to number one killer, or the surprising quantification of smoking damage 1 mutation per 15 cigarettes, or maybe the complex trade-offs involved in screening, the diverse and sometimes bizarre ways lung cancer can actually show up, or the truly transformative potential of targeting those specific molecular weaknesses in the tumor. Lots to think about.
We've certainly aimed to go deep into the provided text, focusing on that essential knowledge, just like experts in the field need to command this complex information. There's always more to explore, of course, but hopefully this chapter provides a critical framework.
Thank you for joining us for this deep dive. We hope it's given you valuable insights and maybe even sparked some further questions for you to explore on your own.
And here's a final thought to leave you with. Considering these rapid advances, especially in targeted therapies and immunotherapy based on detailed molecular profiling, but also considering the ongoing challenges of resistance and figuring out who truly benefits most from which complex treatment. What does the future hold for balancing these increasingly complex, personalized, and often very expensive treatments with the practical needs of accessibility and cost on a global scale? Something to think about.